Good afternoon, and a very warm welcome to today's episode of our talk show series, Let's Talk Primary Healthcare. Would you believe that today is our 14th episode on this journey, especially today when there are so many other interesting global health and public health events and webinars? Today, we will be talking about a very important topic for primary healthcare, that of access to medicines. Many medicines and medical supplies are a core component of primary healthcare. They're cost-effective. Without them, diagnostics and visits may not make a difference, and many are needed for patient comfort and convenience. And yet, we are seeing many barriers undermining their access and appropriate use. For example, I often see data that takes me really aback about the proportion of people with hypertension who are aware of their condition, and yet they do not use medicine as directed. Why is that? Do people continue to face financial barriers to accessing medicines for primary healthcare sensitive conditions like hypertension, diabetes, and asthma? Or are there other factors at play? Do we have success stories of countries that have reduced access gaps? And what advice can we give to policymakers how to facilitate and accelerate improving access to medicines for primary healthcare? These are some of the questions I will be discussing with our panelists in the coming hour. And after that, we invite you to join our breakout sessions in English and in Russian language to hear your successes and your challenges in this area. In the meantime, please use the chat, say hello to us, and my colleagues will also be sharing some important resources with you. And with that, let me welcome our panel and let me introduce them. Welcome, dear colleagues, and thank you so very much for taking the time. First, I would like to introduce Dr. Natasha Asoparty-Muscat, Director of the Division of Country Health Policies and Systems in our WHO Regional Office for Europe. Dr. Péter Weyer, Family Doctor and Assistant Professor, Department of Family Medicine, Semmelweis University, Hungary. Trin Habicht, Senior Health Economist at the WHO Barcelona Office for Health System Financing, and Vanessa Adams, Clinical Pharmacist, embedded in a GP practice in Cardiff and Vale University Health Board in Wales, in the United Kingdom. Welcome, and thank you for joining us. And I'd like to jump into our first round by looking at the evidence. Dear Trin, what does the evidence say? Can people afford to pay for medicines for primary healthcare sensitive conditions in our region?
Good day, everyone. And the short answer is really that not all households can afford to pay for medicines. And that holds true for all countries in our region. However, there are significant variations between countries. And if we look at data evidence, then we see that generally financial protection is weaker in those countries which rely heavily on out-of-pocket payments when financing their health systems. But it is also important to note that it is not a black and white issue. And evidence also shows us that policy choices regarding coverage play a significant role. And hopefully we have a bit more time to come back to policy options a bit later. But if we look at best performing countries, then approximately 1% of households face catastrophic spending. Unfortunately, there aren't many countries that fall into that category. When we look countries with the weakest financial protection, then we find that 20% of households face catastrophic spending. To put it differently, it means every fifth household. That's a lot, that's huge. And across countries, outpatient medicines, our topic today, outpatient medicines are the main driver of financial hardship. And the general trend is that the weaker is the financial protection in the country, the more important role outpatient medicines play. And one last piece of the evidence, what is also important here is that in every country, the poorest households suffer most because of the financial hardship. And outpatient medicines, again, are most important driver of financial hardship, especially among the poorest households. That's in a nutshell about the evidence. So back to you, Melita.
That is actually very powerful evidence, and I believe my colleagues are now pasting the links into the chat where you can access the report of the WHO Barcelona office for the whole of the region, as well as country-specific reports on affordability of health services, including medicines. But this evidence is really puzzling if we think about it, especially for primary healthcare, because the medicines we're talking about, they have proven cost effectiveness. So why do we not see better coverage of these medicines? What are the main reasons? Natasha, may I bring you in to broaden a little bit the discussion on this?
Thank you very much, Melita. Good day to all those who are watching and listening in. And thank you, Melita, for having put this important topic of medicines on the primary healthcare agenda. I think one of the things that often worries me is that we talk a lot about primary healthcare, we talk about the model of care, we wonder and despair about the reasons why primary healthcare perhaps is not taken up to the extent that it should be taken up, and we leave medicines very much in a siloed discussion on their own without bringing them into the heart of service delivery. And let's face it, what can a health professional in primary healthcare do nowadays other than offering a listening ear and empathy? And of course, those are very important. But if that health professional cannot provide access to diagnostic interventions, which is not the subject of today's session, we can do that another time, and access to medicines, of course, the primary healthcare service cannot be complete. Now, you asked a very good question. These are diseases which are so important. They are the illnesses where we can make significant differences, even in our European region, in terms of reducing premature mortality and also reducing complications such as stroke, such as amputations, etc. For many of these medicines, good quality generics, which are perhaps not so costly, could be available. What is not working? Let me offer you a couple of explanations. When we talk about hypertension, diabetes, type 2 diabetes, and hyperlipidemia, these are often quite hidden. You mentioned asthma before. Anybody who suffers an asthma attack will immediately go and get the medicine because it is visible. With hypertension, with diabetes, with hyperlipidemia, these are the silent killers, if you wish, that often, therefore, the patients, if they need to make a choice, will prefer to prioritize other items if they cannot afford to buy the medicines. The second thing is that in many policymakers' eyes, these medicines are often rather cheap. But the paradox is that these medicines are needed by older people with low pensions, by people out of work, by the poorer people, because we know that the burden of disease, particularly NCDs, is higher in these groups. So the second point that we have then is that the people who often need these medicines most are the ones who are least able to afford them. And the third point is availability. We may think theoretically that there is good availability of good quality generics, but often it is not the case. Sometimes people are exposed to substandard and counterfeit medicines. Sometimes patterns of prescribing and dispensing would opt for the more expensive branded medicines that then patients still face severe barriers. And the last point that I would make is that policymakers often need to make choices, and therefore at times they would end up prioritizing the immediately critical hospital medicines rather than these medicines, which again, sometimes people think, you know, these can be bought, they can be afforded. So that would be, I think, my opening statement. Back to you.
Thank you, Natasha. And indeed, there was a lot in there that gives us food for thought, and we will unpack in some of the coming interventions. But before we go on to talk about some practice level and community level factors, I'd like to ping pong back to Trin and pick up Natasha's last point, because in our talk shows, it often comes up that one of the main reasons is that primary healthcare does not feature high on the policy agenda, and in many countries, it continues to suffer in the priority setting and the budgeting process. And this is one of the reasons also why we don't see better medicines coverage. Trin, any very quick pragmatic policy advice, what we can do to counter this?
Thank you, Melita. I think the first and huge shift that needs to occur is to view medicines not as a privilege, but as an integral part of an effective and comprehensive primary healthcare service package, available to everyone, available and affordable to everyone. Because in some countries, we still use a terminology like a privileged group, so which means that only those who are those called privileged have access to medicines and some other type of health services. That mindset really needs to change. And of course, we must create and use evidence to demonstrate to policymakers that investing more in primary healthcare, including medicines, is worthwhile spending. This also means better informed and explicit priority setting during the budget negotiations processes. However, of course, in every country, we have a Minister of Finance that requires that Minister of Health make sure that money is spent efficiently, right? So it's true in every country. And of course, it's very true also when we discuss spending on medicines. And we do need to make efforts in the health sector that money spent on medicines is money well spent. This applies not only to the public budget, this also applies to households' private spending, out-of-pocket spending. And there are multiple ways how to do that. For example, more effective price regulation for medicines, mandatory generic prescription, and so on. So I will stop and back to you, Melita.
Indeed, those are very important policy tools, making a better case for primary healthcare and the spending of medicines, and then spending those resources better on the truly cost-effective medicines and improving prescribing and consumption patterns. And with that, let's come to practice level. Peter, you are a practicing family doctor. Let's stay with the topic of financial barriers. Do patients reveal to you when they have problems purchasing the medicines you prescribe, and how do you handle those situations?
Hello, everybody. Thanks for inviting me in this panel discussion. I think they don't always come up with this problem in our office. We might see that we prescribe an antihypertensive drug, and when we check up blood pressure again, we don't see any changes in the measurements, and then we start the conversation and we start to ask about, have you had the chance to buy your medicine, etc. So, and then it comes up that there might have been some financial issues with buying the prescribed medicine. Nowadays, that in Hungary, we have been using a new electronic system for, I think, 3 years now. We can check whether the patient has bought the medicine at the pharmacy. So it's a bit easier to check whether there was a financial problem with that or any issue with buying the medicine.
It's very important to have these conversations, right, and to dedicate the space to have them. Vanessa, let me come to you. You have a very interesting role. You're a clinical pharmacist embedded in a PHC practice, and this role is increasingly important in many countries, but not all countries have this. What can professionals in this role do to reduce financial barriers to access?
Hi, thank you very much for having me on the panel. So yes, I work as a pharmacist in a GP practice, which has a lovely role being close to the patients and being able to discuss with them I think one of the important things is making sure that they understand what their medicines are for. As you say, especially for medicines which are using preventing long-term consequences, such as medicines for diabetes or hypertension, but even in asthma, just explaining the importance of their inhaled corticosteroid as opposed to simply using the beta agonist, which I think when patients are having to choose which medicine to buy, would potentially go for the one that shows immediate effect as opposed to those that may be having the long-term benefit. So one of the roles is patient education, and I think often in consultations, patients are given a diagnosis or are busy taking that information that they don't have long to sort of understand maybe what the implications are or how long they should be on a medicine. So there's a role there. Part of my role is doing medication reviews, where it's looking at all the medicines the patient is on and making sure that they're not having side effects, making sure that the medicines that they get from different sources, so those from secondary care as well as primary care, are all go together, and that there's no interactions, and just being able to explain to them the importance of each of them, but also looking at if there are some that they no longer need and which ones that they should prioritize if they have got financial constraints. I'm very privileged to live in Wales, and the fact that here prescriptions are free, so patients don't have to pay for their medicines that are prescribed by their GP. But it's still really important for them to then understand, and when we look at how that manages to work, it's understanding that we're preventing, hopefully, admissions to hospital. So it's also looking to make sure that the medicines are appropriate, and that the patients are understanding how to take them, and that as conditions change, they're still appropriate for the patients. Thank you.
Indeed, I think these are very important functions, especially when people have multiple illnesses. And in many countries, we know that primary healthcare's resolutive capacity may not be so strong. So people might be seeking specialist care, getting a prescription here, another one there. And all of that really adds up to quite a substantial financial burden. So having somebody in a primary healthcare setting, or giving this function to primary healthcare to rationalize all the medication use of patients, is a very important function. I think we already started seeing the question of access to medicines through the eyes of practice. So let's stay there for a little bit. And Peter, I would like to come back to you. What other barriers do you see through the eyes of your practice to medicines that are non-financial barriers?
Yes, Hungary is let's say a developed country, so we can afford the most modern medicines in general. But what I see here, and let me give you an example, which is a real problem and would be an answer to your question, is for instance in type 2 diabetes, we have a national guideline which says that management of patients who suffer from type 2 diabetes should be managed by a family physician. But on the other hand, when we come to the prescription of modern drugs, we are not allowed to do that, only when a specialist has seen the patient earlier and said this and this type of medicine should be used. And after this recommendation, we can prescribe the certain drug for 12 months. So there's a, let's say, administrative barrier here, and also we see a big discrepancy between real practice and guidelines. I could give you other examples as well, but I think this is a very important barrier here, what we need to change.
And let me stay with you just for a second. Why do you think that is? What do you think are the root causes why family doctors are not allowed to prescribe what specialists can?
I think it's kind of, let's say, a bad tradition here. Regulations are changing very slowly, and some decades ago there were not drugs available in such a wide screen, or so many drugs, and so all special drugs were in hands of specialists, and this kind of regulation has remained this way. This is one thing. The other thing is that there might be no trust in family physicians. They are trained enough to choose the best for their patients.
Those are very important root causes that I think we need to take into account as we think forward to the policy recommendations. And let me put this in our parking lot, and we will come back to that. But let's go to Vanessa now, and let's take a small detour and hear a little bit more about your role. You began to narrate some of the functions that you practice. Can you tell us what was the main motivation for NHS Wales to incorporate clinical pharmacists into primary healthcare teams, and what your daily work looks like beyond the functions that you have outlined? You're muted, Vanessa.
Sorry. So I think the initial incentive to employ practice pharmacists was partly a shortage of family doctors. So I think obviously our role initially was to do medication. As I said before, I think a lot of patients have started on medicines, and then the follow-up and the checking that they're all right on those medicines and they still know what they're doing is quite a time-consuming element, and GPs are busy. So I think the initial role was partly to do that, and partly, as I say, to try and rationalise and make sure that everybody was on appropriate medicines and not being left on medicines that they no longer needed to take. The role has then developed. So I started out doing mainly reviews, and then as I sort of became more embedded in the practice and the GPs sort of became aware of what I could do and my skills, I started off by monitoring DOAC, so making sure patients were on appropriate doses. And then that evolved into me doing a prescribing course, so that I think back in 2015, pharmacists were allowed to prescribe. So it involved me doing a course through the university on prescribing and focusing on the area of atrial fibrillation. From that, I developed a role of actually being able to prescribe in that area. So doctors often would still refer patients to me, and then I would start them on the appropriate medicines and follow them up. And that was probably about 5 years ago, and since then I've developed and expanded that into other scopes of practice, so that I can now prescribe in a number of different areas. And it tends to be the doctor has made the diagnosis, and I will then adjust their hypertensives or follow up. So all within sort of understood sort of guidelines, and the doctors are here for me to be able to ask questions and ready to give advice as well. One of the advantages, I have full access to patient notes working in the practice, and I see the GPs every day to chat to them, you know, so there is that trust and that embedded in the team, which I think is very important as part of that. And I have access to the blood results from the hospitals as well. Yes, thank you.
Yeah, that's a very interesting narrative, and I think what you're saying here is an important. This function could also be taken up by GPs as well, or family doctors, right? But we are hearing from all through our work a lot of narratives about the workload in primary healthcare settings, and this is a function that requires time. And if I add this to what Peter said earlier of having conversations about with the patients about their ability to afford medicines, that also requires time. So we're coming to this very important dimension of time here, and how to give that time to primary healthcare teams to do these very important functions instead of trying to work through the waiting room and the emails and the online consultations. Vanessa, I'd like to stay with you for a short comeback. Natasha and Trin mentioned that there are population groups that are facing particular challenges, not just with affordability, but other barriers, overcoming other barriers of access to medicines. In your practice, who would be these particularly vulnerable groups? Oops, I think, lost Vanessa. We lost Vanessa, so she disappeared from, there she is. All right, we did not lose her. Over to you.
Sorry about that. Yeah, so obviously there are a lot of different groups of patients who still have problems accessing medicines, particularly maybe the lower socioeconomic groups, and that can be for a number of reasons. Often health literacy is maybe lower. A lot of our patients don't have access to internet resources, and so their understanding of why they've been put on medicines may be different. So, for example, I had a patient recently who had a heart attack and been started on the normal preventative medicines to prevent a future event. And after a month, had stopped taking them because they felt well and they felt better. And so it's making sure that patients really understand what the purpose of those medicines are and why we're giving them to them. Obviously, there are patients who have very busy, hectic lives, and that just remembering to take medicines can be tricky sometimes. And so again, it's trying to think of ways to help them and the importance of why they're on them and which medicines you need to take regularly, which medicines you take when you need them for the condition that they're treating. So the symptomatic medicines. Obviously, dementia is another area where patients sometimes have problems. And again, it's engaging with carers and helpers and looking at aids which can be used, but also sort of simplifying what they're on so that maybe patients take medicines once a day rather than 5 times a day. And again, so that's part of the role, is making sure they're on them, rationalizing actually what they're on.
Yes, indeed, and I think this makes us think that it's important not to take a one-size-fits-all approach, because the barriers in the community and patient level to accessing medicines can be vastly different, and the response also needs to be different. Trin, let me now bring you in. You have listened to the colleagues from practice level. What are your reflections on their thoughts, and how would, in particular, a purchaser reflect on some of these thoughts? For example, like restricting prescription rights, etc. People who are responsible for allocating and using public funds efficiently.
Thank you, Melita, and really interesting discussion here. Let me give you also this time example from my own country, but really trying to put that into perspective of the purchaser. When we look at the co-payment system for medicines in Estonia, it's very complex. And while I won't dig into all the details, I will focus on a particular aspect of it. For a long time, almost like more than 2 decades, there has been an annual spending threshold for the co-payments related to outpatient medicines. And if person exceeds the threshold, an additional compensation mechanism comes into effect. However, if we look at the data, then we see that in the past, only very limited number of people actually benefited from that compensation. And there were few reasons. So the first reason was that the threshold was set at a too high level. So people were not just reaching to that level. The second very important reason was that people were not aware that this type of mechanism is existing, and those who were eligible, they didn't know that they are actually eligible for it. So it's people just didn't know that they can benefit. And the third reason was that the administrative process involved in having the access to that additional compensation was very cumbersome, very cumbersome. It meant that person had to retain all prescriptions, invoices, then do accounting, and then submit the application to the health insurance fund, and finally got the retrospective compensation. And the result was that only one third of people who were eligible to that compensation actually received that compensation. There was an important policy change in 2018. The threshold was lower, which means that more people were able to, like it were eligible for that compensation. But the second very important change was that Health Insurance Fund introduced digital tool or made a change in IT system that now is a central ICT system that is accounting persons' co-payments, and if person is reaching to the threshold, then additional compensation automatically applies. It means that person doesn't need to be aware that this kind of mechanism is existing and automatically starts to benefit from it. And as a result, so more people are eligible to benefit from that additional compensation, and 100% of those who are eligible for it actually receive that compensation. So it's just a very kind of a simple digital tool that can make a huge difference when you see it from patient's perspective. Thank you. Back to you.
I very much like that example. I think it illustrates very well how even with best intentions, sometimes we design policies that actually do not help people. They're overly complicated and they don't consider the end user. But I also like the solution in that digital tools, if they're well designed, they can actually really simplify procedures and make a benefit. We will come back to clever solutions in a moment, but I wanted to give the floor to Natasha. A lot has been said. What would be some of your reflections on the conversation?
Thank you, Melita. And I can totally relate to some of the things that Peter and Vanessa were saying from years of practice. And this is very clear, particularly when I was listening to Peter talking about the fact that sometimes at the level of primary care, you don't have access to the full plethora of medicines. Today, patients have access to the internet. They know what newer medicines are available, and therefore this undermines the trust in primary care, a concept which maybe we might have some time to return to because it will be at the heart of our health systems conference in Tallinn at the end of this year. But also, I think I was looking at the chat, and people are saying there are so many barriers to access. It's a whole ecosystem, and it's true, this is the case. It's not just about the financial protection. Sometimes, for example, in smaller markets, the medicines may not necessarily be always available. And there was also a point made about the shortages that were faced even in primary healthcare this year. But taking a step back, I would always say that the important thing is that we pay adequate attention to medicines and access to medicines when designing our model of care, when designing the balance between hospitals and primary care, when looking, for example, at the composition of the workforce. And very often, pharmacists work in pharmacies and they are not necessarily working closely with the counterparts. And those countries that are enabling now pharmacists to form part of the multidisciplinary team, such as through the important role of clinical pharmacists, of course, this is all very new and very important. But at the end of the day, I think we need to go back to those groups who need the medicines the most and who are often, because of a series of barriers that have been very well described by colleagues, not able to access the medicines and to continue taking them. Because today we are focusing very much in primary care, we are focusing very much on chronic diseases. So here we are talking not about a medicine which you take, for example, for 1 week or two, but for a longer term. And allow me, Melita, perhaps to bring in also medicines for mental health. We haven't mentioned the medicines for mental health. We focus very much on cardiovascular disease, on diabetes. But in primary care, often our colleagues who work there are hampered because of rules and regulations that often limit their ability also to prescribe and dispense medicines for mental health. for anxiety, for depression. We are not talking here about the severe and very chronic and complex mental health disorders, but we are talking about mental health conditions which our colleagues, Peter and Vanessa, probably encounter on a daily basis in primary care, because we have seen that mental health is also an issue. And I think I just wanted to mention this because we tend to forget it. Thank you.
That was really a great summary and segue into our next section. And I think in this first part of our talk show, we really explored some of those ecosystem of barriers. I actually really like that phrase or turn of phrase, Natasha, ecosystem of barriers. We explored some barriers at patient level, at community level, at practice level, and at policy level, which some of it is national policy, but some of it is international policy related to medicines and medicine pricing. So let us now look to solutions, and let's do one round where I would like to ask each of you to put on the table the most promising policies and practices that you think can ease access, improve access to medicines. Vanessa, we will start with you.
Thank you. So I think from my perspective, obviously money is the financial side is really important, but also the patient's understanding of why they're taking the medicine, what it's for, what to do if they do feel that they're getting side effects, and just how long they should be on it. And yeah, the patient education, I think, is and that can come from many different forms. Through the media, through the internet, as well as through the health professionals. And I think within that, it's looking at maybe having some more multidisciplinary training so that we make sure everybody understands the roles of each other and coming up with the same health education for patients and talking the same messages. Thank you.
We cannot underline that enough. Patient education is critical, but how to do it well? How do we do that well in the age of the internet? I think that's something that really merits discussion and possibly a further round of talk show. Peter, you're next.
Yeah, so I've mentioned before that in Hungary now there's a e-health system is available where we can really see everything online, what happens to the patient, whether it happens in a hospital or outpatient service, etc. And it helps us to follow the medicines as well, what we've prescribed. Was it bought by the patient at the pharmacy or not? And also in the pharmacies, the pharmacists can see all the prescriptions, what has been done earlier as well. So I think it's very important for the patient safety, because this way any drug interaction could be seen by the pharmacist as well, and I think that's quite an important thing. Also, we see now in Hungary that the policymakers try to start something like in the UK it was called GPs with special interests. So you can fulfill some kind of training, and with if you pass an exam, you can prescribe some medications, which was in the hands of specialists earlier. We are talking about this for a few years now. I hope within the short future it will happen, and it could give an answer to the problem what I've mentioned earlier. So I think there are good news as well. And on the other hand, I think, because Vanessa, as I understand, in Wales nobody pays for, I mean the state obviously, for the medicines. I was wondering if it's really good, because this way the patients don't see the value of something which was prescribed. So I'm not sure it's good in every case. It's just a short comment on that. Thanks.
That's a very interesting comment. We're going to put in the parking lot for a future discussion, but I very much like your point, and I would like to underline it when you're talking about revision of roles of the GPs, but we should also talk about nurses and engaging them more in this conversation. Like for many areas, we know that when it comes to communication, building the relationship with patients, they're very well positioned to do that, and many countries are moving into that direction. Trin, let's bring you now in. What are the key policies you see and solutions to address some of these issues?
Thank you, Melita. And let me keep the health financing perspective when discussing potential solutions. The first, of course, solution and very important one is expanding primary health care coverage of medicines. Because if we look our region, then we still have countries in our region where basic medicines, for example, like medicines for high blood pressure, are not part of the state-covered benefit package. It means that people need to pay fully out of pocket to have access to those medicines. The second very important solution is also to improve co-payment design for medicines. Of course, it would be just great if there are no co-payments for essential medicines at all, but we also know that is not often the case. If co-payments exist, and what countries can do is, and what is very important, is to exempt low-income households and people with multiple chronic conditions from co-payments. Because if we look our data, we see that these are the groups who are suffering most because of financial hardship. And it would be also important when we discuss co-payment design to prefer low and fixed or flat. So it depends how you like to call it, co-payments rather than percentage co-payments, because percentage co-payments really means that the more expensive the medicine is, more patient needs to pay. But patient cannot choose the disease patient has. Patient is not deciding on the price of medicines. So it's just also unfair to put that financial burden and financial uncertainty onto people. And then, of course, the third one, and then maybe recalling Estonian example here, is we should much more use the potential of digital tools to eliminate administrative barriers. So it's really the aim should be that when we have an administrative part or bureaucracy, if we call it like that, it should be seamless. So it's and then should be automatic if we take a people's perspective. Thank you.
Those are really excellent and quite specific policy recommendations on how to design coverage policies for medicines. And you by now all have the link of the WHO Barcelona office where you can review some of these with the evidence and country examples. Natasha, how about you? What would be the top 2-3 policy recommendations you would like to put forward?
So the first thing is that we need really to empower GPs, pharmacists, nurses working in primary healthcare to be able to be competent, confident, and able to really prescribe the medicines. I very much like the point made by Vanessa that patients need to be seen as part of the team, as partners in this journey. But taking a step back for policymakers, we need to ensure the basis, a quality regulatory system, because otherwise you can end up in the level of primary care, perhaps in a relatively maybe unmonitored environment, far away from the capitals, with substandard medicines being used. So the first thing is to guarantee what there is on the market. The second thing is to have in place the proper pricing and reimbursement or coverage policies, and this means being able to exercise negotiation power and leverage to ensure, for example, that you have large volumes procured, which may enable you to have better prices, better distribution, and that then facilitates access. So I see that there is kind of the clinical side, where the patients and the professionals come together, but there is also how we manage upwards with the industry, the providers, the manufacturers. One of the things, for example, as WHO that we are doing is that we are trying to support also those countries that would like to enhance their domestic manufacturing capacities, because for medicines that are used in primary healthcare, you want really to have good domestic manufacturing capacities or sub-regional manufacturing capacities. I saw this very much, for example, Melita, when I was recently having the medicines policy dialogue in Central Asia, that there is a strong appetite from countries in that part of our region to be able to ensure that they up their domestic manufacturing capacities, because this in turn then allows more security and stability of supply and the ability to ensure also favorable prices.
Indeed, all of you have put on the table a wide range of policies and practices that can help improve access to medicines in primary healthcare, but some of them require quite a big paradigm shift among policymakers in how they prioritize and how they view things, paradigm shift among practitioners, among the population. So this will be our final round, and I would like to give you the floor to articulate what would be your wish for a paradigm shift that would be needed in our health systems so that we can really start closing this access gap. Peter, let's start with you.
Yes, I've been talking about trust earlier, and what we see in the healthcare system, that trust regarding family physicians is very, very high, on a very high level among patients. And I wish also policymakers would have such a trust towards us, and this way they would try to narrow the gap between the guidelines, the professional guidelines, and the reality, the practice, so we can really prescribe those medications which are needed for the patients, and this way we would help the access for those medicines for the patients.
I think that's really critical, and if I may editorialize here a little bit, if policymakers do not trust general practitioners, primary healthcare workers, how can we expect from the population, from the people to trust and seek care at that level of service? So I think this is a vicious cycle which we really need to turn around. But rather than me editorializing, let me give the floor to Natasha. I know, Natasha, you're thinking about this a lot, the word trust and how it affects our health systems. Say a little bit more what you started unpacking earlier about the big meeting in Tallinn and the important role of trust in health systems.
Thank you, Melita. And that's a great point, Peter, and it continues to add important layers to our understanding of trust and transformation and how the two go hand in hand. These will be the main principles at our Tallinn meeting. Melita, you said a paradigm shift. Yes, transformation. And the transformation needs the trust. But in practice, what does this mean? In practice, this means that medicines do not remain an afterthought, and they are really integrated critically when we talk about model of care and when we talk about service delivery. That is the very first thing. And I wish to say that as WHO, our teams are working very closely together to make this happen. The second thing is that there needs to be trust in the system that the medicines that are provided are good quality, that they will be there when one needs them, and that what is being prescribed and dispensed is truly necessary. One of the things perhaps that we haven't talked about, Melita, is the vested interests around the pharma sector. And we cannot be naive. We have to understand that this is, of course, a very important economic sector in many countries with multiple stakeholders. And as policymakers, we need to have an ongoing dialogue with all stakeholders, including the industry. And this is what we are doing with our novel medicines platform, for example, as WHO. But we need then to be able to say, these are the right policies that need to be in place. And we are trying to work, in fact, with our colleagues in Barcelona, with our colleagues in the medicines team, to have this kind of framework that we can bring to the countries, that we can use also to diagnose. Where is the system weak? What is the weakest link? I used the word ecosystem before. That's a complex, a big word. Let's use a simpler word. It's a chain that is only as strong as its weakest link. And we need to have a way of really being able to assess where the weak links are and to put in place the policies in a very determined manner, because this is going to require conversations with people with different interests. But if we truly believe that access to medicines for common chronic conditions where there is a large burden of disease should be available at the level of primary healthcare, we know what the policies to make this happen are. And then we need to be able to push forward and this WHO to support and empower the leadership of our ministries of health to make the change happen.
Very nice, very nice. Let's indeed invest in that. And as you can all see, this talk show is really prepared by our joint efforts between our primary healthcare team, our medicines team, and our health financing team, because we do believe that only together we can make progress forward. Vanessa, let me come to you. What is the paradigm shift you would like to see?
Thank you. So, as you say, there are a number of reasons for barriers to access to medicines. You know, I like the talk of having more local manufacture and making sure that we limit or minimize shortages in medicines, but also they become more affordable and also reducing a carbon footprint at the same time. So I think those are all important points. I think from where I'm coming from, obviously, as a pharmacist, I think being part of a team and using each person's speciality is important way forward. Obviously, as pharmacists, we promote ourselves as specialists in medicine, so that's where we would like to try and show our skills. There are lots of conversations about, as you say, the role of community pharmacists as being prescribers, because they have that potential conflict of interest, because obviously they are run as businesses as well. So there are lots of challenges along the way. As you've mentioned, nurses also a great group to have contact with patients and to be prescribers as well, which happens in the UK as well. I think part of that, as I've said before, is making sure that there's multidisciplinary education available, and as you say, specialising within certain areas so that people are competent within those areas and that their colleagues around them know what their limitations are, but also trust in what they can do, and also that the patients have confidence in us.
Very important points indeed. And I think that brings me to another paradigm shift we often talk about in our program, is that this transformation we're seeing throughout Europe, this increasing move towards multidisciplinary, team-based, networked primary healthcare is not easy, because it requires to rethink roles and responsibilities, and it is not just simply rewriting the terms of reference of each individual, but investing in organizational development of how to play to the advantage of each function and each person. And I think that is what you highlighted in relation to prescription practices and the different roles that different people on the team can play. Trin, you will have the last word on this talk show. What paradigm shift would you like to see?
Yeah, I will partly repeat what Natasha already said and echo my previous comment, but it's a big wish, so I think it's worth of repeating. It's we really should overcome seeing medicines as a privilege or medicines as a standalone area of the health system. We should see medicines as a core part of the comprehensive primary healthcare service package that is available to everyone, that is affordable, and that does not lead people to suffer from financial hardship. That is very important thing, and And maybe it's also like it's part of that. It's a bit unpacking it. And again, repeating Natasha's earlier comment is that if we sometimes still see that people think that these are high-cost medicines. These are these high-cost, relatively low-volume medicines that are the main cause of financial hardship. But if we really look at the data, we see that actually relatively low-cost, essential, high-volume medicines are those which are the root cause of financial hardship, and that pushes people into poverty. So it's, yeah, this is my wish, and of course we all need to work very hard. It's to make that wish come true as well.
Indeed, and I think those are very powerful concluding remarks. Medicines should not be a privilege. Access to medicines in primary healthcare should be a right, because it is the effective way to proceed for everybody. Let's work on these paradigm shifts. Let's work on these policies together. I saw while we were talking that there was a very, very rich conversation going on in the chat. So this is now your chance, everybody, to reveal your experiences. We invite you to 2 breakout sessions. One will be in English, hosted by my colleague Sarah Garner and Jose Cerezo, and the other breakout session will be in Russian, hosted by my colleagues Saltanat Moldoisayeva and Baktigul Akazieva. The links will be posted in the chat. We will leave them open, and please let us know if you have trouble joining, and we will help you. With that, I would like to thank our panelists. Thank you very much for your insights. I so enjoyed today's talk show, and I was reflecting. I think the reason why is because everybody brought something quite different to the conversation, different level of thinking, different vantage point. And I think this is exactly how we can move forward, that we put those together like a puzzle and we design effective policies. Thank you very much for your time. I know that some of you will be joining our breakout sessions, so our viewers will have a chance to actually have further questions to you. And please, when you close the main window, you will have a pop-up survey about our talk show. This is very important to us because we always seek to improve. Please take the 2 minutes that it requires to fill it out, and see you in the breakout sessions. Goodbye.